மீட் ஸ்டார்ட் பண்ணிக்கலாம். அதான் சார். நீங்க வெளியே இருந்து பேச முடியாது சார். சரி பேசு. சார் மேடம் வாங்க. சார் மேடம் வாங்க. மேடம் ஸ்டார்ட் பண்ணிக்கலாம். லைவ்ல தான் இருக்கு. ஸ்டாப் கொடுத்து வச்சிருக்கேன். இப்போ ஸ்டாப் பண்ணிடலாம். ஸ்டாப் பண்ணி வீடியோ அளவு இப்போ பேசுங்க. ஓகே சார். உங்களுக்கு யூடியூப்ல கேட்குதா? சரிங்க சார். சார் மீட் பண்ணுறேன். இல்லை அது கேட்குதா? கேக்குது யூடியூப்ல கிளியரா கேக்குதுங்களா? இப்ப நான் பேசுறது இங்க பேசுறது எனக்கு கேக்குது பாருங்க சார். வாய்ஸ் ஆடியபிளா? ஹலோ சார். ஹலோ யூடியூப். ஹலோ 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 யூடியூப்ல வாய்ஸ் இல்லையா? இல்ல ஒன்றும் பேசல பேப்பர். ஹலோ ஹலோ 2 seconds வருதா? வருது. என்னோட 2 seconds ஆகும். இங்கே அது கொடுத்து சார் நீங்கள் வியூ பண்ணும்போது மட்டும் ஜஸ்ட் இதை மட்டும் ஆன் பண்ணிக்கலாம். வேறு எதுவுமே பண்ண தேவையில்லை. இந்த பாட்டை அப்படியே ஆன்ல இருக்கும் சார். எல்லாமே ஆன்ல தான் இருக்கு. நீங்கள் எதுவுமே பண்ண தேவை. கூகுள் மீட் அவங்க போயிட்டே இருப்பாங்க. நீங்கள் பேசும்போது மட்டும் இந்த மைக்கையும் வீடியோ எடுத்துக்கிட்டீங்கன்னா ஆடியோ யூடியூப்ல ஆட்டோமேட்டிக்காக போய்கிட்டே இருக்கும். நீங்கள் பண்ண தேவை. சரிங்க சார். பேசுறதுனால ஏன்னா மைக்கு கேமரா எல்லாமே இங்கே தான். நீங்கள் பேசுறது அந்த பிபிடி வந்து நீங்கள் எதில் வச்சுருக்கீங்க மாற்றிக்கிட்டீங்க. அப்படியே மெயில் ஓப்பன் பண்ணுங்க. மெயில் ஓப்பன் இல்லை ஷேரிங்கில் போட்டாங்க. எடுங்க ஷேரிங் சரி. இப்போ ஸ்டாப் பண்ணிக்கலாம்ல யூடியூப் ஸ்டார்ட் பண்ணிட்டேன். இப்போ இது மட்டும் யூடியூப்ல போயிட்டு இருக்கு. இப்போ வேணுங்கிற மட்டும் டப்புனு இதை சேஞ்ச் பண்ணி நான் மாற்றிட்டேன். ஸ்டாப் பண்ணி கட்டாயம் சார். செக் பண்ணு செக் பண்ணு சார் மாத்திரை இதில் வந்து அந்த இதில் எப்படி போட்டோம் விர்ச்சுவல் ரியாலிட்டி நீங்கள் வந்துருக்கு. இது அப்படியே இருக்கும். அது ஓட அப்படியே ஓடிட்டு இருக்கும். ஸ்லைடு மட்டும் சேஞ்ச் பண்ணி எல்லாம் ஸ்டார்ட் பண்ணி கொடுத்துட்டேன். நீங்கள் இது எதுவுமே பண்ண வேண்டாம். ஓகேங்களா? இதை மட்டும் இதை அப்படியே விட்டுருங்க. இது மட்டும் இது மட்டும் இதை மட்டும் வச்சுக்கங்க. சரி வேற எதுவும் வேணாம். நீங்கள் சார் மேனுவல் தான் கொடுக்கணும். எதுவும் எடுக்க மாட்டேங்க. நீங்கள் எதுவுமே பண்ண வேண்டாம். ஜஸ்ட் அது வர ஆட் பண்ணிக்க சார். நீங்கள் ஆன் பண்ணும்போது மட்டும் பேசும்போது மட்டும் எடுத்துக்கும் போது வேணும்னா நீங்கள் ஆன் பண்ணிக்க. நம்ம அட்மின் வந்து அதில் கொடுத்துருக்கோம் சார். ஹலோ அட்மின் இதுதான் அட்மின் சார். சார் இதில் பேசணும். நான் அதில் ஜஸ்ட் ஸ்லைடு மட்டும் இதில் பேசலாம். நம்ம சரி இன்ட்ரெஸ்டிங் கொடுத்தா தான் செகண்ட் இன்ட்ரெஸ்டிங் கொடுத்தா தான் போதும். இல்லை விண்டோஸ் கொடுக்கும்போது நான் சொன்ன மாதிரி விண்டோஸில் தான் செக்யூரிட்டி ஃபுல் பேஜ் வரல. ஸோ அதனால் அடுத்து ஃபர்ஸ்ட் ஷார்ட் பேஜ் வரணும்னா அடுத்து வந்து சார் பேஜ் பண்ணி இன்ட்ரெஸ்டிங் கொடுத்து அதுக்கு தான் ஃபுல்லாக வந்துச்சு. அப்படியா? செகண்ட் சார் லிங்க் கொடுங்க. எப்படி வருதுன்னு பார்ப்போம். வரல. இப்போ நான் விண்டோ மட்டும் தான் கொடுத்துருக்கேன் அப்படின்னா ஷேர் ஆயிடுச்சுன்னா ஷேர் ஆகிடும். இது மட்டும் வந்து இது ஓகேங்க சார். இது ஓகே. இல்லை நான் மியூட்டில் தான் வச்சுருக்கேன். ஏன்னா நாமளே இங்கே மியூட் போட்டேன். மியூட்டில் தான் இருக்கு. சரி இருக்கா ஜி சொல்லுங்க ஜி. பேப்பரை கீதா மேடம் வாங்கிக்கிறீங்களா? சரி நான் அனுப்பிச்சி விட்றேன். சரி சரி ஓகே ஓகே. இப்போதைக்கு அங்கே போய் ஜெராக்ஸ் மிஷின் எடுத்துங்க. நான் அதுலேருந்து எடுத்துக்கேன். ஓகே ஓகே. எஸ்கேப் கொடுத்துட்டேன். நீங்கள் பக்கத்தில் எஸ்கேப் கொடுக்கணும்னு பார்த்துட்டேன். அதுக்கு ஃபுல் ஸ்கெட்ச் கொடுத்துட்டேன். இப்போ நான் விண்டோஸ் கீ எடுத்து கீழே வரும். இது வந்துருக்காது. அதை எடுத்து கொடுத்துட்டீங்கன்னா போதும். நீங்கள் இது எதுவுமே பார்க்க தேவை. நீங்கள் வந்து அட்மிட் மட்டும் எப்படி ஸ்டார்ட் பண்ணுறது 2:30 மேலே ஆகிடும். எல்லாத்தையும் அட்மிட் கொடுத்துரு. எவ்வளோ பேர் வந்து ஃபஸ்ட்டு நீங்கள் அட்மிட் கொடுத்துருங்க. அப்படியே இருக்கட்டும். ஸ்டார்ட் பண்ணுறதுக்கு முன்னாடி ஸ்டேஜ் கொடுத்துருக்கேன். ஸ்லைடு வந்து பண்ணிக்க ஸ்லைடு போனதுக்கப்புறம் மறுபடியும் எஸ்கேப் கொடுத்துட்டு வெளியே வந்துட்டு ஸ்லைடு போகுது. எல்லா ஸ்லைடும் அதுக்கப்புறம் நீங்கள் நார்மலாக பேச ஆரம்பிச்சு. ஏன் அப்படி சொன்னால் 2 மானிட்டர் இருந்துச்சுன்னு வச்சுக்கேன். இது ஒன்றுமே ஈஸி. ஒரு மானிட்டர் இருந்துன்னா இந்த ஸ்லைடு ஒரு பக்கமும் இது ஒரு பக்கமும் வச்சுக்கோன்னா ஈஸியாக நம்ம பார்த்துக்கலாம். மூவ் பண்ணுறது ஈஸி.
இதில் அட்மிட் பண்ணால் அங்கே தான் கிளாஸ் நான் சொல்லுங்கள் பாருங்க.
எல்லாமே மைக்கெலாம் ஆஃப் தான் இருக்கும். உங்களுக்கு கேட்குதுங்க? வாய்ஸ் கேட்குதுங்களா? ஸ்பீக்கரில் மைக் இருக்கா? சரி ஓகே. இல்லை யூடியூப்ல வந்து ஸ்டார்ட் பண்ணி வச்சிருக்கேன் மேடம். கேட்கும் மேடம். அது வந்து சைடில் வாய்ஸ் எடுத்துக்கணும். அது கண்டிப்பாக எடுத்துக்கணும். அது எதிர்ப்பு எடுத்து போடுங்க. செகண்ட் ஹோஸ்ட் செகண்ட் மாதிரி ரெண்டுக்கும் ஹோஸ்ட் கொடுத்து ஹோஸ்ட் எல்லாம் ஹோஸ்ட்ல உட்காந்து எல்லாம் ஆட் பண்ணுங்க. ஏன்னா ஒவ்வொருத்தையும் கிளிக் பண்ணிட்டு 2:30 ஹெல்ப் வருவாங்க. சர்வீஸ் ஆப்ஷன் சரி அப்படி மாற்றி இல்லையா? வேற ஏதாவது பண்ணிக்கலாம். ஸ்டார்டிங்கே பண்ணியிருக்கோம். அதில் கேப் பண்ணி போட்டு மெயின் கேமராலே பண்ணியிருக்கோம். சைடில் சைட் ப்ரெசன்டேஷன் இல்லாமல் இந்த பேசுகிறவங்களோட சைடில் பின் பண்ண முடியாது. பின் பண்ண முடியாது. பின் பண்ணோம்னா எடுக்காது. அது என்ன ஆகும்னா சில பிபிடி போட்டிருக்கிறீங்க. பிபிடி போடும்போது இதே ஒரு ஸ்லைடில் வரும்போது என்டையர் ஸ்க்ரீன் கொடுக்கும்போது மட்டும் தான் அந்த மாதிரி அப்படி வரும்போதுனா வியூ ஆகிட்டே இருக்கும். அப்படியே புரியுதுங்களா? இப்போ இத்தனை பேர் தான் வருதுங்க. இத்தனை பேர் வராமல் வெறும் ப்ரெசன்டேஷன் வியூ மாதிரி கொடுக்கலாம். இப்போ இவ்வளோ போய்கிட்டே இருக்கும். ஸோ இந்த மாதிரி அந்த மாதிரி போயிடும். அவங்க ஃபோட்டோ வந்துடும். பட் ஆனால் பார்த்தோன்னா போய்கிட்டே இருக்கும்ல. லேயர் மாதிரி அதான் சொன்னாங்க. இன்ட்ரோ மட்டும் பேசுகிறவங்களோட வீடியோ இருந்தால் இதெல்லாம் நீங்கள் க்ளோஸ் பண்ணும்போது சும்மா நீங்கள் அதை ரைட் கிளிக் பண்ணி பின் பண்ணி தரேன். திரும்ப பின் க்ளோஸ் myself or everybody. நமக்கு இன்னொரு மானிட்டர் இருந்தால் நமக்கு பிரச்சனையே இருக்காது. இதை எடுத்து நான் மைக்கை மட்டும் நீங்கள் முடியும் போது ஜஸ்ட் இது ஸ்லைடு மட்டும் நான் ஸ்லைடு மட்டும் வச்சுக்கிட்டேன். அந்த சாரோட ஃபேஸ் எனக்கு தெரியும். ஸ்லைடு மட்டும் முடிஞ்சோடனே ஸ்லைடு மட்டும் சரிங்களா? முடியும் போது எஸ்கேப் வருது. எஸ்கேப் கொடுத்துட்டு வெளியே வந்துட்டீங்கன்னா போதும். வந்ததுக்கப்புறம் நீங்கள் போய் போயிட்டு நீங்கள் பேசுறதெல்லாம் பேசிக்கலாம். அட்மிட் கொடுக்கணும், சைடு அட்மிட் கொடுக்கலாம். நான் அது மட்டும் இது ஒன்று மட்டும் தான் சார். நான் அது ப்ரோ எப்படி நான் கேட்டேன். ப்ரோ மட்டும் நான் எப்படி நான் சொல்லிட்டேன். நான் இது கேட்டேன் அவங்கள்ட்ட கோர்ஸ் எப்படி பண்ணுறது அப்படின்னு. அதை அவங்க வந்து இன்ஜினியரிங் தான் பண்ணியிருக்காங்க. அதை இப்போ பண்ணணும்னா அது கரெக்டாக அதை எப்படி கேட்கிறோம் அந்த இருந்து ஓப்பன் பண்ணி வச்சேன். இது முடிச்சதுக்கப்புறம் நீங்கள் பிபிடி உள்ள போயிட்டு நீங்கள் ஓப்பன் பிபிடி மட்டும் ஓப்பன் பண்ணிருக்கீங்க. ஓப்பன் பண்ணதுக்கப்புறம் நீங்கள் உள்ள போயிட்டு என்எக்ஸ் விண்டோஸ் போயிட்டு அதை எடுத்து சரி ஓகே.
Yeah, good afternoon, everyone. So, welcome everyone for the second day of faculty development program. The next 50 minutes and an hour so, I will take you through my experience, core business after stroke. So, this session I'm just going to deal with trunk control measures post stroke. The session objectives are to give you an overview about neurophysiological and biomechanical connections of trunk and the assessment of trunk and how to measure the trunk in stroke recovery tracks. So as we know, the pyramidal system involvement, that is the corticospinal lesion in stroke results contralateral hemiplegia. So that is the spasticity of upper limb and lower limb. On the other hand, the extrapyramidal system, particularly the reticulospinal and vestibulospinal tract, are responsible for maintaining the postural tone, particularly the axial part of the body, head and neck and the torso. Post-stroke, the extrapyramidal system also get involved because it has direct connections from cortical system. So therefore, unilateral supratentorial leads and results spasticity on the contralateral side and low tone in the torso. Also, the extrapyramidal system has bilateral innervation on the torso. So, the biomechanically speaking, the tonic muscles, that is the postural muscles, that are important for stabilizing certain part of the body. So therefore, the phasic muscles can effectively work. For an example of lumbricals, we have two medial lumbricals and two lateral lumbricals. Medial two lumbricals are bipennate musculature. So this is the slide about neurophysiological connection of torso, and then the biomechanical connections of torso. I was just talking about the lumbricals. By the virtue of medial two lumbricals, uh, the bipennate musculatures, its role is to stabilize the medial two fingers. So therefore, we manipulate the middle and index finger with the thumb during the hand toss. So what we understood with the simple mechanics is that the tonic muscles are critical for phasic muscles to act. The similar kind of construct is there in torso as well. The transverse abdominis and oblique abdominis are the tonic muscles, they are the deep seated muscles. They provide the postural background for the torso. So, the phasic muscles, particularly the rectus abdominis and erector spinae group of muscles, can selectively move the torso for functional tasks. These deep seated muscles are having slow twitch axillary fibers with more small motor units and a large number of muscle spindles. Uh, these are the muscles that are the first one to contract any torso-initiated movement, as well as their reaction time is faster. So they act prior to any arm or leg initiated movement that we say postural set. Okay, these group of muscles are critical for anticipatory postural control mechanisms. And unlike the muscles of extremities, they attach from bone to bone. The dorsal musculatures are not attached from bone to bone. Majorly, they are attached with the facial connections to linea alba. For the torso to work efficiently, either from an upper torso or a lower torso, they need a stable fixation, either at pelvis or linea alba. So what happens in a unilateral stroke? As I said before, the torso is innervated bilaterally, one side having more innervation compared to other side. The unilateral stroke results weakness of the oblique abdominis on one side. So therefore, the contralateral side would pull the linea alba. So resulting a kind of situation where one side oblique is short and other side is lengthened. So we know the muscles cannot function efficiently when the optimal length is maintained. So the person cannot do the kind of selective movement. And we learned in anatomy these oblique muscles are interdigits with the serratus anterior and it has facial connections to the gluteus maximus. So any force or tension generated in the torso can be transmitted to the extremities through these facial connections. So the torso is critical for maintaining the posture as well as to perform a functional task using upper limb or lower limb in coordination with the front musculatures. Right. So the familiar notation is proximal control influence the distal extremities. But ideally, in a getting of situations from supine to long sitting, the one stabilize the lower part of the body and selectively contract the upper part of the body to come to long sitting position. After stroke, the selective control is lost. The kind of dynamic stability is lost. So instead of using the selective control mechanisms in the absence of the deep-seated postural muscle control having no tone, the individual uses the rectus abdominis as a whole, resulting in a kind of a mass flexion reinforced with the spasticity in the lower. Even in a simple task of pelvic bridging, they excessively use the erector spinae group of muscles, resulting more lumbar extension. On the right side, the lady after an acute stroke attempts to roll towards an affected side and unaffected side. Rather than using an abdominal muscles, the lady uses the extensors. Using the mass extension, the lady attempts to do. Right. So the next comes the restricted trunk mobility and what happens when there is a poor trunk control. In the absence of trunk control, during an arm task, that is the hand to mouth or taking a hand to a cup of water, the individual will not dissociate the torso and scapular musculature. So this dissociation is lost after stroke. So since the post is compromised and trunk control is poor, the individual uses the axioscapular muscles for stability, so resulting excessive arm retraction. But ideally, this muscle is meant to have a stability. In a compromised situation, they compensate for mobility. So you find more retraction from the scapula, that is the excessive retraction on the upper torso as well, resulting a limited spinal mobility towards the less affected side. On bottom image, you could see a person with left side hemiplegia has restricted thoracic rotation towards the less affected side. So this happens in a chronic stage. There are soft tissue limitations would further result to articular limitations in this. Right. So how we define or describe trunk control or trunk performance? So it's nothing but the ability of trunk muscles to keep the torso in alignment and adjust weight shifts with a selective upper trunk or lower trunk movement in coordination with the functional movements of the extremities during self-initiated or external force-initiated perturbations. This is how we defined trunk control or trunk performance in one of the papers that we published long ago. Right. So I said about selective control and the stability. Right. The trunk also plays a critical role in stability. I would define the stability as dynamic stability of a trunk. What is it? It's about the uh, ability of a torso to remain stable but active. So therefore, the other part of the torso can independently move in different directions or in different plane during the functional task. So this kind of movement, we say coordination. For example, you need to reach out something laterally, your lower part should be stable so that you can selectively move your upper part of a torso. I would define upper trunk above T8 and T8 below lower trunk, and you include the arm, then you say upper body, include leg, and then you say lower body. Right. So this is one of our paper that we published in neural regeneration research, address the assessment methodologies that one can use in clinical setting for evaluating the torso. So in this paper, we listed down three clinical utility measures. The first one is trunk control test, and rest of the two are trunk impairment scale proposed by Eden and another one by Fujiwara. And we come to trunk control test. What is it about? Trunk control measures the trunk performance early after stroke, particularly in an acute care setting. The trunk control test is an ordinal scale having the maximum score of 100, where you grade 100 if the person could do a task, and grade 0 if a person cannot do a task, and grade 12 if the person performs the task with some kind of a compensation. In trunk control test, one measures four items: the rolling from supine to the weaker side, rolling from supine to the stronger side. I would say this is less affected side. And the third one is the sitting up from lying down position. The last one is the sitting ability for about 30 seconds. The trunk control test is a predictor of motor and functional recovery measured using Fiedler-Mayer assessment test and Barthel index. This test has sensitivity in an acute stage. So this can pick up the impairment seen in an acute stage, trunk impairment seen in an acute stage, but it lacks sensitivity in a chronic stage. Sensitivity is nothing but you rule in. So you have to identify the impairment. Since this has limited evaluation of quality of trunk movement, it is not sensitive in chronic stage. That means the person with chronic stage can score 100 out of 100 in trunk control test. Doesn't mean that the person doesn't have a trunk impairment. That's what it says. So this has a moderate correlation with trunk strength. The next comes the trunk impairment scale produced by Verheiden. It has three subscales. It's an ordinal scale. You have static sitting balance, dynamic sitting balance, and then coordination. In static sitting balance, you measure the steady state of sitting balance. The therapist cross over the sound leg over the affected leg and look for the steady state of torso, and then you ask the lady to cross over the unaffected leg over the affected leg and look for the postural stability, and you score accordingly. You look for any compensation, or the lady takes any support using a sound arm. That's how you grade. Sorry for the technical glitches. We're permitting some of the delegates for the presentation. Right. So then the dynamic sitting balance. The dynamic sitting balance measures the lateral postural stability. You measure the lateral flexion initiated from upper trunk and then lower trunk. The patient is asked to take the elbow to the bench and look for appropriate shortening on that side within the lady completes, or look for any compensation in the lower extremities in the absence of trunk control. So rate accordingly. In a lower trunk lateral flexion, you ask the person to lift the pelvis towards the rib cage and look for a shortening and look for a compensation. And lastly, the coordination subscale, it measures the dissociation between upper and lower trunk. The person is asked to take the upper torso. The patient is asked to move the shoulder forward 6 times and look for the symmetry and how many times the lady performs in 6 seconds. Right. So So the trunk impairment scale, you have a revised version where you will remove the static sitting balance component and you will consider only the dynamic sitting balance and coordination. This is applicable in people who have already attained the sitting balance and have some kind of a walking ability, and then you need not to measure the static sitting balance. You can use one of those scales, depends on the patient's the steady state in sitting and standing. And the next comes the trunk impairment scale proposed by Fujiwara, where you measure 7 items. 5 items are specific to Fujiwara, 2 are drawn from SAS. So I hope now the slide is visible. The perception of trunk verticality, trunk rotation muscle strength, writing reactions are the components, and plus the 2 items of SIAS, that's the verticality and abdominal muscle strength are included. The perception of trunk verticality, the patient is blindfolded and the therapist tip the patient sideways and ask the patient to perceive the trunk verticality. If the patient perceives trunk verticality degree less than 10 degrees, then you grade the maximum score. The person perceives when the torso is placed more than 30 degree and feels that is vertical, and then you grade 0. The trunk rotation muscle strength is measured asking the patient to roll over towards the affected side, and you look for how well the patient can roll over. Grade the maximum. Patient can clear off the shoulder blade but can't roll completely. Then you grade 2, and you see only the visible contraction at an obliques. You grade 1. Similarly, you grade trunk rotation strength on an unaffected side as well. The writing reflex. This is the reaction though. The patient is nudged sideways and look for the writing reaction, how strong and how big the patient regains the balance, and you score accordingly. If the reflex is strong and can bring the body to correct sitting position immediately, you grade 3. If the patient cannot have adequate writing reaction, then of course therapist should support and get back the patient to sitting position, score less. The abdominal muscle strength is measured. The patient is seated in a reclined chair or a wheelchair, and give a resistance at sternum and ask the patient to come forward and look for the strength in the abdominals and grade accordingly. However, the scale is not widely used, though this is a very good scale, particularly in a subacute stage of stroke recovery. But we don't happen to find this trunk impairment scale proposed by Fujiwara in clinical research. Those who are interested in conducting a clinical trial and looking at a different construct of trunk recovery, one can use this. Trunk muscle strength. How do we measure trunk muscle strength? The trunk muscle strength had been widely tested using isokinetic dynamometer and handheld dynamometer in the early 90s. Though the interventions are seen in 2010, but this was picked up. This involvement of trunk weakness was picked up long ago. Isokinetic dynamometer showed the trunk flexion extension muscle weakness as well as the trunk rotator weakness. And the authors, the Tanaka and colleagues, said that the trunk muscles are weaker during high velocity trunk movements. The recruitment is poor, particularly the high velocity fast twitch fibers. And then Bohannan conducted a couple of studies using handheld dynamometer and showed trunk lateral flexors are weak bilaterally. So, in a nutshell, the trunk muscles are involved bilaterally after stroke, even with clinical observation or use of any one of these trunk utility muscles, trunk control test or trunk impairment scale, or measuring the trunk muscle strength, you happen to find trunk is involved multidirectionally. There were a couple of papers that address the involvement of trunk proprioception. So that's to document the trunk proprioceptive error in people with stroke. The trunk proprioception is involved. There is poor trunk position sense accuracy in people with stroke. And we also validated the test procedures of how to measure trunk strength. In a clinical setting, we used a handheld dynamometer, Postural dynamometer, and we validated the test procedure, and we found the trunk muscle strength measuring handheld dynamometers more reliable. Yes. So those are interested in how to measure the trunk muscle strength using dynamometer can read this particular paper published in Journal of Clinical and Diagnostic Research. So what are the clinical correlations that is available with trunk and other variables? Trunk control and trunk muscle strength measured using trunk impairment scale, trunk control test, as well as the trunk strength by the dynamometer in chronic stroke showed a positive relation with balance capacity, walking, and functional activities measured using web balance scale, Trinity Poma, walking speed, Barker index, respectively. The one who has better trunk function at discharge would show better functioning during the follow and also walks faster or walks longer distance during follow. So the trunk control, the trunk function is an important predictor of future function. Right, this is an interesting work that I and Wahad and published in Topics in Stroke Rehabilitation. So where we measure the trunk control, muscle strength, and balance confidence in community dwelling people with stroke, we found that the trunk control measured using trunk impairment scale and core muscle strength with handheld dynamic is positively influencing the balance confidence of community dwelling stroke survivors. So we measure the balance confidence using ABC scale that you're familiar with, that is the activity specific balance confidence scale. It measures the perception of balance. It measures one's balance confidence during daily activities. That's the ability to do task with a confidence. How confident you are while doing daily activities like walking across a road, walking in a crowded place and get bumped, and how confident you are. It's about the perceptible ability of balance against opposed to balance ability, balance capacity person. So we felt these balance capacity measures have a positive influence on balance confidence. Right. So the trunk behaves quite uniquely in standing and sitting. And we know the most major portion of the torso is attached to pelvis. And imagine the trunk is hypotone. It loses its tone and becomes weaker. It results pelvic obliquity. Right. So the people who work with musculoskeletal conditions are familiar with the palpation meter, a palm device that is widely used in measuring the pelvic obliquity in essay dysfunction. So we use this palpation device to measure the pelvic obliquity in stroke patients. We found the pelvis is excessively tilted forwards, nearly about 5 to 7 degrees, and tilted excessively on the most affected segments, about 5 degrees. Right. So we conducted on reliability study and found that the pelvis is tilted excessively anteriorly and laterally. And we also conducted another work that got published in Journal of Neuroscience in Rural Practice, where we compared the pelvic obliquity with weight-bearing asymmetry in the community dwelling stroke survivors. We found there was a positive correlation between these two variables. Weight-bearing asymmetry is measured finding the difference between the the weight bearing ability on to weighing scale upon the body weight. And another work we published in Journal of Neurology and Clinical Neuroscience. So this is an interesting work though, where we measure the pelvic alignment in standing and also measure the trunk control and the motor recovery of lower limb with the Brunstrom recovery staging. We found, so there was a positive correlation among these variables. Interestingly, we found there is a strong association among these variables in Brunstrom recovery stage 4. So this is a notation, and we are familiar about the force couple, the concept of relative stiffness and relative tightness. The hip flexors and the trunk extensors work together in conjunction to counterbalance the force from abdominals and hip extensors to neutralize the pelvic. In case if one muscle undergoes weakness and the other muscle will go for relative stiffness. So this is the concept that we are familiar with. So in stroke, when there is a poor abdominal control, poor trunk control with hip extensor weakness, the pelvis tilts excessively forward, resulting in the hip flexors tight. Right. So this is the pelvis is a component of it also in standing, in our understanding. Right. So then we wanted to measure the trunk motor function using fetal Mayer and the hip muscular strength with the dynamometer. And we found these variables had a strong positive correlation with pelvic obliquity, weight bearing asymmetry, and gauge speed measures. So with these work, what we conclude is the trunk performance is positively influencing a balance and mobility related parameters in stroke. That's a hypothesis. That's a hypothesis testing. We need to prove this testing in an intervention studies. That's a different context altogether. Right. So now I will just run through a couple of performance arrays used in trunk assessment. The first comes the posterography assessment. One as colleagues conducted research about measuring the balance using work balance scale and lateral balance capacity with a force plate. So here the test procedure is patient needs to reach up sideways and look at the limits of stability and the weight bearing excursion on a force plate. The colleagues observed that the patients with stroke have limited ability to do a lateral weight towards the most affected side, and this ability is positively correlated with the work balance scale. Another colleague, Chinese colleague Chen et al., they conducted a similar kind of work where the patient stood on a force plate. They were asked to do a forward reach task with the trunk bending, and they observed that the weight bearing was more towards less affected side. They hardly shift their weight towards the most affected side. So the notation is patients after stroke would limit their weight shift ability towards most affected side. The dynamic analysis study. Right. So the patient is this experiment is about the forward trunk inclination and look at how the trunk behaves. The patient is seated on a chair and the feet is kept on a force plate. Now the patient is asked to lean forward, asked to do a forward trunk flexion. Typically, a normal individual, a healthy individual, would lean forward from hip. So basically, the forward trunk inclination happens at hip. So this requires forward trunk leaning, requires a trunk control as well as hip extensor control. So this is a healthy. This is what a healthy individual would do. What a person with stroke would do. Person would simulate this kind of situation. The person would do a trunk inclination by excessive trunk hyperflexion, but where he or she would not do forward translation of the COM. That's not reflected on the force plate. So, what this particular research would say, the person after stroke would do a forward trunk flexion, but cannot do an appropriate trunk inclination or weight sit forward that is preparatory for sit to stand. This we do in a clinical setting, sitting balance training. Patient holds both arm and do a forward reach outs and lateral reaches. Ideally, the patient is doing excessive trunk flexion. We are not working on a trunk control. That's what I just want to stress upon with this particular investigation. And then comes the lateral postural control. As I said before, the trunk can selectively move either from upper trunk or lower trunk. Here, the task is asking the patient to do a lateral reach outs at an arm level. So, ideally, what happens? The trunk, the head and neck contracts first over a stable pelvis. The pelvis will not move. The lower trunk provide a postural stability. So the person can move from upper trunk. He can effectively elongate of the weight bearing side. What happens in stroke, having lost this kind of postural stability? This was investigated with the surface myography study. When such task was asked among people post-stroke, they couldn't show this kind of recruitment pattern, this kind of timing, where you find more trunk trunk and pelvic compensatory movement followed by upper trunk and hip movement. So this shows trunk has poor dynamic stability of the stroke. And then sit to stand movement analysis. The patient is seated and the feet kept on force plate, and there are markers kept to find the trajectory of the torso movement during sit to stand. The Silva and Douglas colleagues found that patients after stroke sit weight towards the less affected side, and the trajectory is more towards the less affected side. And this particular movement, the trajectory, has some kind of a causal relationship with trunk muscle strength. So similar work by other couple of people, regardless of the sound side feet placement, whether it is kept ahead of affected side or unaffected side or behind the unaffected side, the people after strokes tend to shift their weight towards the less affected side. So one critical thing what we find among people post-stroke is they have limited weight ability towards most affected side. How well these trunk control measures are used in stroke recovery trials. Until 2010, there were not many studies on trunk recovery, not many clinical trials. Now there are a lot of clinical trials available. There are a couple of systematic reviews, meta-analysis are there. In fact, you happen to find a Cochrane review on trunk control. So here I'll define my ideas limited to trunk control measures in stroke recovery trials. The trunk impairment scale by Verheyen and the trunk control test are widely used as an outcome in stroke recovery trials. So this is from one of our paper from neuroscience medicine, where the trunk was treated using a stable support medium. It was a simple plinth where you train the patient about the selective motor control of upper torso and lower torso in supine and seated position, and we measure the trunk impairment scale. We found it was beneficial. So nearly 4-point changes we could find on a trunk impairment scale after 4 weeks of training in a chronic stroke. And then another interesting work we published in clinical rehabilitation, where we compared the trunk rehabilitation using an unstable support medium, that is the physio ball, opposed to similar kind of rehabilitation strategies using the stable support. That's on a plea. And we found both groups improved on trunk impairment measures, the gross score as well as the dynamic sitting balance and the trunk impairment scale. The interesting finding was the people who performed the trunk rehabilitation, trunk exercises using unstable support showed better changes in dynamic sitting balance and coordination subscale. So what we conclude is that those who use an unstable support medium at an early stage the stroke recovery can recover better in their uh, coordination component and dynamic sitting balance. That's quite difficult to change in stroke. The trunk coordination, particularly the lower trunk control, is quite difficult to change. So what we hypothesis is that the postural perturbation of the physiotherapy provided some kind of postural activity in the tarsomusculatus. Right, so this is a paper, the comparison of physioball and plinth exercise regime on trunk control in acute state patients. And we also conducted another trial about imagery, truncal motor imagery, where a patient was shown about the typical trunk movement, and then we showed the patient himself performing the trunk exercises, where the patient get an idea about how he would perform, the kind of knowledge of results and performance. Then the patient was practiced with physical trunk rehabilitation strategies. We found these truncal motor imagery strategies was beneficial in improving trunk control measures. So this is another paper that we published in Journal of Stroke and Cerebrovascular Diseases. This is one of the largest trials that we conducted, having so nearly 150 patients. And we treated them for 6 weeks and then followed them up 3 months and then followed them up until 12 months. So we found the people who practice trunk exercises either on a stable support or unstable support showed improvements in multiple variables, particularly the trunk control measures compared to the standard care. So this gains were retained during 12 months follow. And what interestingly we found was there was no statistical difference between the stable support and unstable support trunk regimes group. However, both of them improved compared to standard care. The improvement was 4 point in a trunk impairment scale, that is very much clinically relevant. But the experimental groups, the two experimental groups, did not show statistical significance between them. And what we conclude is that at a chronic stroke recovery, probably we can use one of those tools to produce a similar kind of recovery, or you have a structured rehabilitation strategy that would self-sufficient to produce the desired outcome. This is another large study that we conducted in people with stroke, and we published in American Journal of Physical Medicine Rehabilitation, where we measured different outcome measures besides the trunk impairment scale. We measured the activity specific balance confidence scale as well as trunk strength. All the variables showed statistical significant improvement. The interesting finding about trunk strength is about the rotation muscle strength. Nearly 50% of trunk rotation muscle strength will improve after treatment. That's nearly 10-pound change after treatment. It's quite interesting about this particular study, because we gained the mobility and then we provided the opportunity for these muscles to recruit and having a control and then build up the strength. So this is one of the very important finding out of this particular work. And then lastly, the another paper on pelvic stability along with trunk activity, where we found people who had undergone pelvic stability and trunk control exercises showed beneficial effects on hip motor function, trunk functioning, as well as in the daily activities. Thank you. Just a moment. I will take a couple of questions. Speaker. Just a moment. I'll just take. Speaker. So I can take a couple of questions from you. Chat box to take one. Are there any questions? How can we deal with flaccid stroke patients regarding hip mobility and stability? Right. If flaccid stroke patients is recovery, right? So acute stage, the one idea is standard physiotherapy care to improve the tone. Sometimes facilitating strategies to improve the tone, and then work with trunk control. For example, of pelvic bridge, the flaccid patient would not do pelvic bridge and do passively pelvic bridge. So what you have to do, you have to give a appropriate hands-on facilitation on obliques as well as the obliques in order to recruit them. So there's muscles participating in the so in an acute stage, in a very flaccid stage, because if you don't have any tone, you have to build up the tone for the patient to actively move. So most of these strategies work on facilitation principles. There are hands-on strategies where marketing also stages. Simple thing would be the pelvic rotations. Rotations are the key. Upper trunk rotation, lower trunk rotations, some kind of an assisted movement, active assisted kind of an exercises are beneficial to build up the tone as well as to improve the tone exercises.
So, Captain, did you mention about movement and element reasons trunk control mobility and stability?
So the next question is whether our paper mentioned about abdomen element lesion. No, we never mentioned about element lesion. In fact, we never mentioned about human lesion. Stroke itself, upper motor neuron lesion. Yes. We wanted to give an importance about addressing their extrapyramidal systems go on postural stability. Till 2010, the papers were talking about spasticity, upper limb or lower limb. We wanted to emphasize that the extrapyramidal system also receives an indirect cortical impact. Any movement from the extremities and torso influences extrapyramidal system, therefore it activates the postural toe and the trunk control. So we never addressed about the lower motor implantation papers. So mainly we wanted to say that trunk is involved as a whole.
Is there any specific trunk control measures for
Is there any specific trunk control measures for pediatric conditions? There are. So even you can use trunk impairment scale. There are different tools that you can time trunk control measures, cerebral pulse. In PubMed, you happen to find a couple of tools. The trunk impairment scale is valid in pediatric population, particularly cerebral pulse. Unilateral spastics. Yeah, sarcoma, described. ECMS, TLS, that's what I just pointed out. Sarcoma. Are there any questions? There are no questions. So we don't rate separately. Idea is, if you require an expertise to place a patient on an unstable support medium, safety is a concern and person answer to control the patient and the support surface is unstable. The idea is the unstable support surface movement beneath the patient results a kind of a postural perturbation that activates the postural muscles. That's the concept. So you don't specifically address hip or torso. It's mainly to enhance the coactivity of the dorsal muscles. They're sleeping and you place them, so you just will waken them. That's the idea. Fine. Thank you for your patient listening. Hand over the session to see if we are getting good results with the stable surface, we have to consider unstable surface in our not compulsory. Because always you have a standard deviation and confidence interval. Even in a clinical trial, one show improvement. Some patients show improvement, some do not. So you may not do these are the recommendations. Right? You just see case by case. Put it hands-on and you can use a stable support alone, surface alone, and go ahead with it. So it's an alternative. Another tool in PT. That's it. Fine. Thank you for your patient listening. Hand over session to the moderator.
I would like to extend our heartfelt gratitude to Dr. Karthik Babu for sharing his expertise with us today on the critical topic of trunk control measures and stroke recovery. Sir, your insightful presentation has deepened our understanding of the crucial role that trunk control plays in post-stroke recovery. Thank you everyone for your active participation so far. It's now my pleasure to invite our second presenter, Ms. Mangaleshwari Manjari, MSc MPhil in Clinical Psychology, who will be speaking on the assessment of stress, anxiety, and depression. Ms. Manjari expertise in psychodiagnostics and psychotherapy, intellectual disability. She holds 3 publications and recipient of 4 world records. Please join me in welcoming Ms. Manjari. Over to you, Ms. Manjari.
Good afternoon to one and all who have been connected with me virtually for this program. So I extend my warmest gratitude to our chairman, Dr. Nalaji Palaniswamy, our trustee madam, Dr. Gavamani D. Palaniswamy, our medical director, Dr. Edmund M. Dikoto, our principal, sir, Dr. Karthik Babu, sir, and vice principal, ma'am, Mrs. Kalpana, ma'am. And I extend my warmest gratitude to all my fellow colleagues for providing me with all the support. So today, I'm going to talk about the outcome measures for the psychological components, the stress, anxiety, and depression. So first of all, we need to understand why is it so important to talk about the psychological aspects of understanding about the patient. So the most commonly, we need to understand the first and the foremost study which is more responsible at this point of time is about psychoneuroimmunology. So it is understandable that any person who is being psychologically disturbed would definitely have a compromise on his neuronal system, which in take have a vulnerability towards his immune system. So when the person is physically down or physically ill, it is obvious that he might undergo some kind of psychological disturbances and vice versa. When a person is having any kind of emotional or psychological disturbances, invariably experiences some kind of physical system. So understanding about the body and the mind relationship is very important for a better researcher or a clinician. So any patient into consideration, be it a physically ill or psychologically disturbed, invariably undergo 3 major psychological disturbances, be it stress, anxiety, and depression. So this takes up a stand of a person developing stress which might become an anxiety or a depression. So anxiety and depression both goes hand in hand. For the development of these particular symptoms, it starts up with a stress as a psychological disturbances. So when we are assessing a person, we need to understand either like here I'm going to focus on either you being a clinician when you are assessing your patient, nor being a researcher having a data collected from the subjects. In the psychological assessments, we consider the therapist to be the researcher who is taking up the research work, and the participants who are like from whom we are collecting the data, we call them as subjects. So the general instructions, what we have to be providing for all the subjects is that any data what we collect from them will be kept confidential. So if you are in the mindset that you are preparing the data only for the research purpose, you have to explain it very clearly and carefully to the patient about for what purpose and for what reason you are collecting the data from him, or how it is going to be used. So you have to give him a greater, in order to provide a proper rapport, we need to make them understand that the data will be kept confidential, and at any point of time the individuality of the the person will not be revealed. The second one, whatever the assessment we make, we have to ask the patient to read the statements or the questions very carefully. So you have to be in a better position to understand about the tool in a very clear way, and in the understanding about each and every statement and question, so that whenever the patient is having any kind of a query, you need to have a hold on to make him understand about the particular statement. So predominantly any questionnaires or the inventory which we use in the assessing the psychological components are predominantly in the questionnaire or the inventory form. So we need to tell them, do not spend too much of time in one particular statement. Why? Because once the person is more towards spending time, there could be a lot of ideas popping in his mind, so that the data what we collect from them may not be true, or sometimes they could fake the data. So it is always essential to make them be prepared to give the responses which best suits them in a very immediate and spontaneous way. So while we are assessing for the stress, anxiety and depression, we need to make them very clear to understand the statements or the questionnaires for the past 1 week into consideration. So except one particular scale which I'm about to discuss about, that alone will be considered for the past 2 weeks. Other than that, the first three scales what I'm about to discuss will be considering the last 1 week, and including the day when we are assessing the particular questionnaire. And here we have to make it very clear in stating them that there is no right or wrong answers for any particular statements or questions. So they need not worry about whether their responses would be genuine or not, because each one of us are unique, and each of our psychological traits are also not comparatively similar to one another. So definitely the data may not be 100% same for both the individuals, even considering the same diagnosis. So we have to make them very clear that no right or wrong answers will be representing for each of the statements. So now I'm going to get into the picture of explaining some of the outcome measures for stress, depression and anxiety, for which I would start up with a very basic understanding about the three psychological components. The first and the foremost thing is stress. So when you call the name as stress, initially it was only considered in the engineering field. Any friction which is caused is considered as stress. So when talking about stress in the healthcare professional system, it is something where the pressure which is built in within the body and the mind for the subjects or the patient. So here it is a state of worry or mental tension which the person undergoes, which would definitely affect both their body and mind. As in my previous slide, I explained about the body and mind interaction. Definitely, this particular disturbance which is causing both to the body as well as mind would definitely have an influence over their psychological component. So any factors, anything for that consideration which is creating the stress for the individual, you call it as a stressor. So these are the predisposing factors which could bring in damage to the person. So now this is the first tool which I am going to talk about as an outcome measure for three components, that is stress, anxiety and depression. So this is the depression, anxiety, stress scale, which in short you call it as DAS. This was initially having 42 statements. So this was initially with 42 statements, and then they switched over to cut shorting it to 21 statements, and now in the recent trend there is also DAS 10, which is the very shortest version of DAS. So this particular tool is used to, like, you get three components that you could assess: stress, anxiety as well as depression. This is in a 4-point Likert scale where it consists of 21 statements. So this 21 statements, they have to mark their answers in 0, 1, 2 and 3 format. So 0 considering that it is never applicable to them, 1 considering to some degree it might applicable to them, 2 means it's considerably higher than that, and 3, it's majority of the time they go through that particular phase. So that is what is this DAS 21 is into consideration. So this was developed by Peter and Sydney in the year 1995, and it is a quantitative measure. So whatever the data you could collect, it will be in the quantifiable analysis. So the total score what we could get is from 0 to 63, because 21 statements, so majority if they mark it as 3, you would get 63, and the total time taken to complete this test could be approximately 4 minutes, and it is used for the patient from 17 plus. So 17 plus. So there are two versions. One is for the youth, that is the depression, anxiety, stress scale for the youth, and as I told you, there are the shorter version also, which is DAS 10. So here there are 3 categories. Under each of the domains there are 7 items each. So while we are as a cumulative score, you will get the score for stress, anxiety and depression. So which would give us an interpretation for each of the domains individually. So this particular tabular column which is being exhibited on the screen is your interpretation. So as you perform the particular test, once you get the cumulative data, you could understand in what category the person feels. So here you will get a comparative analysis of either the person is affected with stress, anxiety or depression, and to whatever the greater level the particular assessment could be followed. So all the particular tests what I've been discussing in this presentation is having a great internal consistency and it is highly reliable tool. So this particular tool has a high reliability of 0.93 and depression in each of the domains also there is a very much high internal reliability. So the next domain what I'm going to talk about is anxiety. So any person who is experiencing anxiety will have a threat or apprehension towards the futuristic aspect. So whenever a person is experiencing anxiety symptoms, in your clinical assessment, you could find out the statements which are highly referred to the futuristic aspects. So once you understand, like நாளைக்கு நான் என்ன பண்ண போறேன்னு தெரியல, இல்ல என்னுடைய வாழ்க்கை எப்படி போக போகுதுன்னு தெரியல. So these kind of the statements would be always referring to the person having a anxiety symptoms. So when you talk about anxiety, there could be a continuum where at the minimal continuum you call it as nervousness and the maximum level you call it as a panic attack. So when you considering, like before starting up my presentation, I was a bit nervous because we are very much apprehensive towards how the presentation is about to happen. So that is considered as a nervousness, which is not considered so highly disturbing, because as of the time duration exceeds, the person becomes fine. But when you call it upon the panic attack, it is something equivalent for a cardiovascular attack. So when a clinician or a researcher is assessing for something, if a person is having a panic attack, we will not be very sure in either the person really has some kind of a cardiac issues or it is a psychological pathology. So we as a clinicians have to have a better hold in understanding or ruling out the biological pathologies and then treating them for the psychological aspect. So the outcome measure which is specifically used for anxiety could be state trait anxiety inventory. So here there are two components which you could assess in one particular tool. So state anxiety and trait anxiety. What is the state anxiety? In a particular given situation, how much the person is apprehensive or feeling that kind of a disturbing factor. So it could be considering the situation or a person or an object or any particular stimulus or any particular event. So any of these is considered as the state anxiety. Trait anxiety is something where the innate personality of the individual itself is anxious. That is, a person could be having a higher end of neurotic tendency. So this neuroticism is something where the person feels hesitant to talk to people or face some social situations, or the person would feel nervous in all the situations. So example, I could point out the famous movie of Dr. Kamal Hassan sir, Tenali. Yes, so that is something where the person is feeling anxious about everything. You call it as a generalized anxiety disorder. So that one, it is a free floating anxiety. Person will face anxiety situations, or they feel nervous about each and every aspect. So those kind of a thing which is considered as the personality trait of the person. So here this particular outcome measure could assess either the state, whether at a given point of time the person is feeling anxious, or whether the personality of the individual itself is being anxious. So both these kind of a measure you could assess by using the that is state trait anxiety inventory. So this was developed by Spielberg and many others in 1983, and it could be assessed by 15 plus age. It is a 4-point Likert scale, and the state trait. So there are two forms, form Y1 and form Y2. So this form Y1 is considered as the state anxiety, and form Y2 is responsible for the straight anxiety. So while the first one, the state anxiety, the options would be from not at all to very much, and for the trait anxiety, it is from almost never to almost always, because the first part, that is the state, is considering the current scenario, current situation. Yes, the second part, that is the trait anxiety, is reflecting the personality of the individual. So we need to understand whether at most of the time whether he feels that way, or only at a given situations or the given point of time they will feel that way. So that is why these kind of variations have been kept in this particular options. So the score range would be from 20 to 80. So each of the domains have 20 questions each. So considering if a person is answering to the maximum of 20 questions, they would get a score of 80. And the minimum score, if they pick up 1 as the minimum response for each of the statements, then there could be 20 as the minimal score. So here, the higher the score, higher the anxiety. So that is how this particular thing has been interpreted. It would hardly take 10 minutes of time to complete the assessment. At the end of my presentations, I would show you all the PDFs. So now I'm moving on. So the STI has a high test and the pre-test reliability, and the internal consistency is also ranged from 0.86 to 0.95. The third tool which I am about to discuss is hospital anxiety depression scale. So in this particular scale, you could assess the anxiety component and depression component in the individual. This was developed by Zygmunt and Snaith in the year 1983. So here it is a very shortest tool which you could complete within 5 minutes of time, where it is only 14 statements. So in each of the domains, that is in anxiety, you could have 7 statements, and in depression, you have 7 statements. This is also marked in 4-point Likert scale, where the score could range from 0 to 21, because 7 maximum score of 3 in each of the domain could lead you to 21 as the highest score in each of the domains, and lowest score as 0 if they pick up 0 as the response. So the items of each of the domains have been displayed in the tabular column, and the interpretation states that if a person for both the anxiety or the depression category, if the particular score is between 0 to 7, it is considered as normal. They do not have any kind of a psychological disturbances. If it is from 8 to 10, it is considered as mild anxiety or mild depression. 11 to 14, it is moderate, and 15 to 21, it is considered as severe. So this particular scale also has an excellent internal consistency, and in Cronberg's alpha, it is being valued by as 0.82 to 0.83. And the third variable which I'm about to discuss is depression. So when we spoke about anxiety, it is something pertaining to the futuristic aspect. Likewise, any person who is experiencing depression should have a significant loss in the past. So when anxiety is pertaining to the future, the depression always occur or happens in the past. So some kind of a significant issue or loss should have occurred for the patient or the subject in the past. So it could be a loss of a loved one, it could be a financial constraint, it could be a loss of a status or promotion or some prized possession. It could be anything. Even the death of a pet animal could experience could make a person to experience depression. So, considering depression, the person would not feel so comfortable connected with the current day-to-day life. So, there would always be dysfunctions either in the personal, social, or occupational level. So, personal, they would not feel connected with other people. They always feel isolated. எதுலயும் ஒரு interest இல்லாம, they don't feel like working on. So these kind of the aspects what the person could experience when they have a personal dysfunction. Social dysfunction, the person will not have an interpersonal relationship. They would not mingle with others. They always wanting to be alone. They would not participate in community activities, or they would not find any interest to get along with people or attending a wedding or any particular aspects. And when you consider the occupational dysfunction, the person would never feel productive in his work area. That is, the focus or concentration towards the particular aspects would never be there, which would invariably have problems in a lot of absenteeism or lesser productivity level, do not have a proper relationship maintenance with the superiors or the subordinates, and so on. So this Beck's depression inventory was developed by Dr. Aaron T. Beck, who is the father or the founder for cognitive therapy. So this particular aspect, he has a varied view in understanding the cognitive triad, that is the negative cognitive triad of a person. That is, any person who is experiencing depression would invariably have a negative view towards themselves, towards others, and towards everyone around in the world. So according to them, they feel that they are having helplessness, hopelessness, and worthlessness. Worthlessness is pertaining to the past events. இதுவரைக்கும் நடந்தது எதுவுமே, it is not something which I could cherish for. அப்படின்னு அவங்களுக்கு தோணுச்சுன்னா, it is a worthless feel. Helpless அப்படின்னா, at the present point of time, there is nobody to take care of me, or there is nobody to help me out. அப்படின்னு இருந்ததுன்னா, it is helplessness. Hopelessness means they cannot see something positive in the near future. So these three aspects could be very well established by using this particular outcome measure, Beck's depression inventory. So this tool is predominantly assessing the symptoms of the person, that is the intensity of depression in the subjects. So this could be used from the age group of 13 plus, and the four major categories which you could assess is, you could assess the cognitive domain, affective domain, somatic domain, and vegetative symptoms of the patient by using this Beck's depression inventory. So the cognitive domain, we all clearly understand any higher mental functioning, that is planning, categorizing, organizing. If the person is having any attention deficit or concentration issues, so all these domains could be assessed. Affective, it is pertaining to the emotional aspects of the person. Somatic, we all understand, it is about the physical symptoms. So any person who is experiencing depression would always have symptoms experienced in the neck and the shoulder, or in the upper part of the head region. There would be pain or representation of pain or discomfort. Vegetative, it is talking about their sexual desires, their sleep module, and their appetite and things like that. So this one particular tool, you could assess the variations of 4 different domains of a person who is experiencing depression. So the highest possible score for the whole test is 63, because there are 21 items and the maximum score is 3. So 0 to 3 is the score range. So when a person scores 3 at the maximum level, it is 63 and the lowest score is 0. So in the vegetative component, there are multiple choices or multiple options which is being provided. Like more specifically, when we talk about the item 16 and item 18. So these two domains are talking about the appetite factor and the sleep factor. So here the patient would have a confusion that 2 or more options may be applicable for them. So if at all they feel that 2 or more options are applying for their their life, you have to encourage them to choose an option which is the maximum level. Say for example, if it is 1B and 2C or 2B is considered na, எது maximum score அவங்க கொடுக்குறாங்களோ 2B அப்படின்னு கொடுத்திருந்தாங்கன்னா அந்த 2 will be the maximum score what they could give for that particular item. So this is a particular statement format which is one group. Like when you talk about the first item, it is a group, it is a cluster. So on the cluster they have to choose. So this particular tool would give you a clarity or understandability about the severity of the symptoms. And the posted a tabular column represents the interpretation of the data. So if the person's score is between 1 and 10, this is considered as normal. So why is that normal? Any person who is undergoing a grief, that is a person's response towards a death of a neared one. So if a person is experiencing grief, invariably the person would undergo the symptoms of depression for about 6 months. So 6 months, if a person is experiencing these symptoms, it's considered absolutely normal. So we will not be able to give a diagnosis of depression. So adanala, if a person is coming to you and they are into grief, that is they have lost their loved ones and because of that they are experiencing the symptoms abdina, definitely we have to wait and see whether the symptoms are getting down. Only then, even after 6 months, if it is not the symptoms are not getting lowered, then we need to consider whether it is a clinical depression, and until then you are not supposed to diagnose the person to have a depressive features. 11 to 16 is considered as a mild mood disturbances, 17 to 20 as borderline, 21 to 30 as moderate, 31 to 40 as severe, and over 40 it is considered as extreme depression. So all the tests, as I pointed out, as a very good test, retest reliability and internal consistency. So the major limitation what we as a psychologist think about the BDI is that it is a self-report measure. So any person who is experiencing a psychological depression or psychological disturbances would not be able to give us accurate data about their symptoms. So adanala, considering only the data from the patient side or from the subject side may not be highly valid. So another, as a clinician, we are having the we have to have an upper rule in understanding about their clinical interviewing. So in the clinical interview how the subjective and the objective analysis other base panni you can give the scores. And this is predominantly assessing only the severity of the depression, nor the social factors or the genetic predispositions have not been tapped. So another, if a person is having a family history of suicidal tendency or a family history of a person successfully committed suicide, so andha madri irundaduna, there is a high vulnerable factor for the patient experiencing these symptoms. So those aspects have not been tapped up in BDI. So another, this is a self-report code test. So considering this, clinical interviewing is also a mandate which as a therapist or a researcher we need to take it into consideration and take it forward. So now I shall just show you the scale. So this is the Beck's depression inventory, the latest version. So this has 21 items, and as I told you, the 16th item and the 18th item has multiple options. So the person has to choose either of these, like so maximum எதுல இருக்கோ அது வந்து you have to take it out. HANS. So this is the HANS, that is the Hospital Anxiety and Depression Scale, which has 14 items, and it is a very easy tool, which is very much time, easily user friendly as well as easily done in a very minimal amount of time. So this is the state trait anxiety inventory. So this has 40 items. So 20 items for the state anxiety and 20 items for the trait anxiety. Yes, so with this, I have completed my presentation. So definitely considering the psychological aspects of the subjects or the patients is also highly, it's a high responsibility of the researcher or the therapist to consider and, take it forward for the well-being of the patient. Thank you so much for your patient listening. So if you have any queries, I'm happy to answer. Ma'am, could you be please louder? Yes, ma'am. There are each of the items. I will just show you. So in each of the items, is the tool visible on the screen? Just yes. Is it visible now, ma'am? Yeah. So this has a 21 item, and each of the item has a representation of S, A, D. Could you see that next to that? So that represents, yeah. So that represents the items of, you could get the items of stress, anxiety and depression, individual items would be reflected, and your scoring sheet. Each of the psychological questionnaires or inventories have a specific scoring sheet and manual. So when you are procuring the psychological assessment toolkit, it has the scoring sheet and the manual. So on the manual layer, it will be represented the items, how it has to be scored, how much of the scoring, அது எல்லாமே டீடைலா அதுல கொடுத்திருக்காங்க. Ma'am, I'm not able to hear you clearly, ma'am. Your voice is breaking. Yes, yes, ma'am. Exactly, exactly. Ma'am. Hello. Ma'am, could you please repeat me what you have said? Yes. Yes. Yes, ma'am. Yes. The the cumulative score of the stress, all these stress items together, you will get the total score of the stress.
That's another question. One second, ma'am. 1 second. We have one more question in the chat box. Can loss of loved one can impact a person unknowingly after years, causing depression? So we'll answer this and we'll get back to your question, ma'am.
Okay, ma'am. Thank you.
Yes, I got a question from Ms. Ramyanandam. So, can loss of a loved one can impact a person unknowingly after years, causing depression? Definitely. Here I understand that the impact of depression had already, the person has started experiencing depression, and then maybe at that point of time, the grieving period not taking a proper treatment protocol follow பண்ணாம இருந்ததுனால கூட the person could have got into depression. So in the 6 months அப்படிங்கிறது, it's just a window period. So after that, if we need to have a monitoring about their symptomatology, and if we feel like 2 months, 3 months, 4 months out இருக்கும்போது the symptoms குறையணும். Suppose if it is not happening, we need not wait until 6 months of time. We need to take a call in treating the patient.
Thank you, ma'am.
Yes. Any other questions?
Now we can just apply these scales for conditions to in our clinical works.
Yes, sir, definitely. This I have, mainly focused for the physiotherapist. Since this faculty development program is purely organized for the physiotherapist, so I have considered these 4 as the major tools which any physiotherapist could use in a very user-friendly manner.
Completed CPT and cognitive behavioral therapy.
Very nice, sir.
But in some cases and in some instances, I couldn't able to utilize these scales for heart treatment protocols to get back to patients with them for their own work. What can I do for that?
Okay, so there are n number of tools, there are n number of assessment strategies which we could use, but as a clinician, we should have a upper hand in understanding what is more required for the patient. Because when you talk about anxiety, depression, when you take upon any physical ailment the person is undergoing, for example, if a physiotherapist is taking a patient with a spinal cord injury or a multiple sclerosis or stroke, you consider any particular module, the anxiety or depression is invariably present. So it is the clinician who has to understand what kind of tool is applicable. So it has to be tailor made. So considering the social aspects of the patient, the background of the patient, what is he undergoing in the psychological domain, or what is essential for your research purpose, considering all these aspects, we need to choose what kind of tool could be applicable. So for example, whatever the tools I have discussed upon in HAD scale or depression anxiety DAS scale or the BDI, in all the three things you could assess the depression level. But in your BDI, that is the Beck's depression inventory, if at all, say for example, you are assessing or you want to do a research in finding out whether your particular physical therapy, what you are providing for the patient, is having an influence over decrease in the symptomatology of psychological elements or depression in the patient. அப்படியா இருந்தா, if you use DAS, it will only give you an idea of what is the depression scale or what is the score, anxiety score, or what is the stress score. அவ்வளவுதான் கொடுக்கும். ஆனா if you use BDI, it gives a more precise value for your research work. அதனால what is required for your purpose of understanding about the patient, it is the idea of the therapist or the researcher to choose what kind of assessment tool would be more applicable for your particular study.
For special children like autism or ADHD children, what are skills we can use for them? Are they affected with anxiety or some depression children? What can we do for that?
Okay, so considering the special children into consideration, so whatever the tools what we have discussed now is always it is almost 15 plus. So it is not used for children population, but we do have psychological assessment for the children also, but it is predominantly for the typical children. It is like for the normal population. So there is no particular psychological assessment which you could directly use for special children. Instead, considering the data what you could get from their legal guardians, that is their parents or the first degree relatives, அவங்க கிட்ட இருந்து நம்ம datas collect பண்ணலாம். But because since they do not have that kind of a developmental maturity, we will not be any particular tool which is considered for the normal population may not be applicable for special children. பீடியாட்ரிக்குன்னு தனியா யூஸ் பண்ற டூல்ஸ் இருக்கு. நார்மல் பீடியாட்ரிக் குரூப்புக்கு நம்ம அதை யூஸ் பண்ணிக்கலாம். பட் ஸ்பெஷல் சில்ட்ரன் குரூப்புக்கு நம்ம கண்டிப்பா we have to consider their parents details or the details collected from their parents or from their legal guardians.
அப்படி பார்த்தா டிஃப்ரென்ஸ் வந்து அப்போ பேரண்ட்ஸ்க்கும் சில்ட்ரனுக்கும் டிஃப்ரென்ஸ் வேற இருக்கும். இப்போ வந்து ஒரு சில்ட்ரனுக்கு அசஸ் பண்ணுற மாதிரி இப்போ சில்ட்ரன் அஃபெக்ட் ஆயிருக்காங்க, அப்போ பேரண்ட்டும் சேர்ந்து அஃபெக்ட் ஆயிருக்காங்கன்னா அதுக்கு என்ன செய்யுது? ரெண்டு பேரும்
So கண்டிப்பா வந்து அந்த ஸ்பெஷல் சைல்டுன்னு வரும்பொழுது they may not give us the very much valid data. இப்போ உனக்கு இப்போ for example there is one particular tool which one particular statement which says that how well I take up my fear factor அப்படின்னு இருக்குன்னா அந்த குழந்தைக்கு ஃபியர்னா என்ன, அதை அந்த கொஸ்டின் ஸ்டேட்மெண்ட்டை எப்படி படிக்கணும், அது எதுவுமே அவங்களுக்கு தெரியாது. ஸோ அவங்க அதை இன்ட்ரோஸ்பெக்ட் பண்ணி கொடுக்குற டேட்டாஸ் வந்து நிச்சயமா நம்மளுக்கு ஒரு ரிசர்ச் பர்பஸ்க்கு டெஃபினெட்லி இட் வுட் நாட் பி பாசிபிளி யூஸ்ட். அதனால இப்போ நம்ம யூஸ் பண்ண டேட்டாஸ் எதுவுமே அந்த மாதிரி இருக்காது. இப்போ நான் பேரண்ட்ஸ் கிட்ட கேட்கணும்னு சொல்றது கூட இட் இஸ் நாட் த டேட்டாஸ் வாட் த பர்சன் இஸ் ஃபேஸிங், த பேஷண்ட் ஆர் த ஸ்பெஷல் சைல்டை பத்தி நம்ம கேட்கறது இல்லை. ஒருவேளை அந்த குழந்தைக்கு ஏதாவது பய உணர்வு இருக்கா, தனிமையில இருப்பாங்களா, இருட்ட பார்த்தா பயமா, இல்ல யார்கிட்டயாவது புதுசா போய் பழகுவாங்களா, அந்த மாதிரி கேட்கிற இது வந்து இட் இஸ் ப்ரிடாமினென்ட்லி அப்ஜெக்டிவ் அனாலிசிஸா தானே தவிர சப்ஜெக்டிவ் டேட்டாஸை நம்ம கண்டிப்பா பேரண்ட்ஸ் கிட்ட நம்ம கேட்க போறது கிடையாது.
Okay, thank you.
Thank you. Thank you. Yes, ma'am.
Can you please tell me whether stress, depression, and
Definitely.
sleeplessness in the night, and also lack of productivity, and also lack of interest in the job opportunity.
Yes.
Total world is going to end like that.
Yes.
So we need to support them.
Yes, ma'am. Yes, ma'am. So when we talk about the vegetative component, that is the biological reflection, so any patient who is coming to us will project with the symptoms only stating that they, ma'am, could you please mute your call so that,
Yes, ma'am. Yes, ma'am.
Thank you so much, ma'am. So it is stated that they come up with a reflection. If a person is having a depression, they would not come and tell that I'm always feeling dull or I'm not able to concentrate. They will not project their symptoms that way. They always say that தூக்கம் சரியா வர மாட்டேங்குது, இல்ல எனக்கு weight loss ஆயிடுச்சு, இல்ல weight gain பண்றேன். So always the reflection would be in the biological functioning. So when a person's psychological disturbances is popping up, the first reflection would always be in their sleep pattern and their appetite pattern. இது ரெண்டுலயும் disturbance இருக்கு அப்படின்னா கண்டிப்பா there is a red flag which is popping in to understand more about their psychological components.
Okay, thank you. So can you tell me some remedial measures for that also?
Yes, ma'am. Yeah. So the first and the foremost thing is the technology could be used in either ways. It could either boost our productivity. So the foremost major component which is disturbing the sleep and the appetite, what I personally consider by seeing a lot of patients, is the gadgets. That is your mobile phones, your any gadgets for that consideration. So as we all are aware of taking care of ourselves, that is you take bath daily, you mend your nails properly, you groom yourself properly, idellam taandi your sleep hygiene and your the mindful eating practice. So these two are the major key factors which we need to focus, so that whatever I'm about to talk about, the disturbance of the sleep or the appetite, is being taken care. So first and the foremost, let us take about sleep. So sleep அப்படின்னு பார்த்தீங்கன்னா கண்டிப்பா you should have a routine pattern of sleep. So by night 10 o'clock you are winding up your day na, by maximum 10 o'clock you have to go to your bed. By morning 5 o'clock have a regular sleep pattern which is followed, and the bedroom is meant only to sleep. So there should never be any other influences of putting all your dirty clothes on your bed, or increasing so much of sound system in your sleeping area அந்த மாதிரி இருக்கக்கூடாது. And there should always be a liquid control after 6 p.m. So 6 p.m. க்கு மேல ரொம்ப fluids எடுத்துக்கிறது கம்மி பண்ணிக்கணும். And there should be a routine, you know, when you are going to bed, if you are comfortable reading a book or listening to some soothing music, you can do that. But especially gadgets into consideration, 1.5 hours before we go to bed, we have to put off all your mobiles. Why? Because the blue screen which is emitted in your gadgets is somewhere tricking your mind that the hormones which is being secreted in the daytime is being secreted. Upper your brain is getting confused whether I need to work on or I have to shut down. So only when there is a good sleep, the next day productivity or either your betterment of working the particular day will happen. So another, these are the simple sleep strategies which you could follow. Sleep eating patterns in a pathingana kandipa you have to have a mindful eating practice. So what you eat, what is the consistency of the food, how it is smelling, or you know what is the odor or aroma. So all these should be in your focus. You have to put away all your gadgets even at that point of time.
So we have one more question. Is there any specific scales for trade-related anxiety, ma'am, by Mr. Prashant? Also, he has extended his question. Like certain personality group, people have more anxious for everything. How to deal with that in rehabilitation setup?
Yes. So when we talk about this state rate anxiety, as you pointed out, in any personality inventory, that is one particular personality inventory, you call it as neo-FFI. Neo means neo-Freudians. Freud has given a lot of research work in the area of psychology. Adulayu, especially personality components, he has put in a lot of viewpoints. So the followers have created the big 5-factor inventory, which is called as neo-FFI. So it is, you could assess 5 major components. The acronym which we use is OCEAN. That is a person's openness, conscientiousness, extraversion, agreeableness and neuroticism. In the Anja tendencies, you can find out by using the neo-FFI tool. That is a personality tool, but still personality assessment, as Mr. Prashant pointed out, avangalodiya anxiety component, which is that neuroticism is nothing but assessing the anxiety version of the person. So you number kandipa we can assess. So அந்த மாதிரி any personality inventory you use, we have certain components of anxiety also to be assessed. So how to deal with that in the rehabilitation setup is like, are you asking about how to deal with the anxiety patients, or what? Could Mr. Prashant be more specific on that? Yes. Okay. So when when a patient comes to a physical therapy, the first and the foremost, we need to have a clear professional boundaries. Yeah, abdina. இப்போ suppose for example a physical therapy காக அவங்க உங்ககிட்ட வராங்க அப்படின்னா, they will not be winding up the session within 1 day or 2. So கண்டிப்பா they will come for multiple sessions. அப்போ you also have a very much quality time to spend with the patient. அப்போ when you are talking with the patient, it is not just the exercise protocol what you are going to follow. You will have a general conversation which is built, and the general conversation built பண்ணும்பொழுது you can understand more about their psychological domain. So if you feel as a physiotherapist, if you feel that the person is having some kind of a psychological disturbances, invariably the person has to be referred to a psychiatrist or a psychologist. அது பண்ணும்பொழுதுதான், because Until or otherwise the psychological components are treated, definitely how much ever the interventions as a physiotherapist you point out or you provide to them, it will never be effective, as effective. Apdina, they will not be in the mindset. Say for example, you are teaching a particular exercise for them to follow for 3 days. அப்படில 3 weeks follow பண்ண சொல்றீங்கன்னா அந்த 3 weeks அவங்களோட மைண்ட் செட் கிளாரிட்டி அண்ட் கான்சென்ட்ரேஷன் இருந்தா மட்டும்தான் நீங்க சொல்றது என்னன்னு அவங்களுக்கு புரிஞ்சுக்க முடியும், அதை அவங்க ஃபாலோ பண்ண முடியும். So once if that is not there or that is not done, then definitely it is compromising on the development of the increase in severity of the psychological component, as well as non-compliance in the physical therapy. Adanala definitely providing them with the understanding or psycho education about their psychological disturbances, அதை provide பண்ணிட்டு physical therapyயும் நீங்க கொடுக்கும் பொழுதுதான் அதோடைய effectiveness பெட்டரா இருக்கும் சார். Thank you so much.
Thank you, Ms. Manjari ma'am, for shedding us light on assessment of stroke, assessment of stress, depression, and anxiety. Your comprehensive overview on these critical mental issues and its assessment methods has been both enlightening and practical. Thank you once again for your valuable contribution. Thank you so much, ma'am.
Thank you, sir.
Thank you, participants, for your impressive interaction with speakers. And now is the time to close the session. Tomorrow we'll start again at 2 o'clock afternoon. Thank you.
So these snacks are very good. Have it.
Check பண்ணாதான் சார் உங்களுக்கு பிரச்சனை. நம்ம இது பண்ணிட்டோம், போஸ்ட் பண்ணிட்டோம். சார் சார் வந்துட்டீங்களா? உள்ள வந்துட்டீங்களா?
எடுத்துக்கலாமா? நம்ம ஆல்ரெடி போஸ்ட் பண்ணிட்டோம்னா
வந்துட்டீங்க சார். ஓகே சார். ஒரு நிமிஷம், நான் கொஞ்சம் பேர் போகணும் சார். ஒரே நிமிஷம் வெயிட் பண்ணுங்க. இன்னொரு 5 பேர் இருக்காங்க. சார் யூடியூப்
ஆஃப் பண்ணல அது ஆஃப் பண்ணா எல்லாம் போயிடும் இருங்க அது யூடியூப்லேயே வருதான்னு பார்க்கணும் அதுக்காக தான் வெயிட்டிங்க அங்கிருந்து பண்றாருன்னா யூடியூப்லேயே ஆகுதான்னு பார்க்கணும் அதனால ட்ரையல் போட சொல்லுங்க அது பிரச்சனை இல்லை சதீஷ் மட்டும் பிரபாக் சார் சதீஷ் கூட சொல்லுங்க யூடியூப் ஓடிட்டு இருக்கு செக் பண்ணணும் ஒருத்தர் அட்டனன்ஸ் ஆட்டோமேட்டிக்கா வந்துடும்
நம்ம இது பண்ணா அது எல்லாமே
சொல்லிட்டே இருக்கிறாங்க நான் தவிர நான் உள்ளே இருக்கிறேன் திருப்பி போடுங்க
ஸோ ஒரே செகண்ட் லைன்ல இருக்கேன் யூடியூப் அது மட்டும்
நாலு பேர் தான் இருக்காங்க
ஆமாம்
அதான் யோசிச்சுட்டு பிரின்சிபல் ஆன்சர் எடுக்கலாமான்னு பேசுறீங்க கேக்குதா சரி பேசுங்க பேசுங்க
சார் சொல்லுங்க சார் யாரு பிராக்டிஸ் சார் சரி சார் பிராக்டிஸ் சார்
பிஸியா இருக்காரு சரி பரவாயில்ல சதீஷ் வர ஆரம்பிப்பாரு சரி இப்போ கார்த்திகை இது பண்ண சொல்லுங்க
சார் ஸ்லைட் ஷேர் பண்ணுங்க சார் ஸ்லைட் ஷேர்
கார்த்திகை ஸ்லைட் ஷேர் பண்ண சொல்லுங்க ஒன்றும் பிரச்சனை இல்லை
இல்ல யூடியூப்ல போயிட்டு தான் இருக்கு அது பரவாயில்ல
அவர் வீட்ல இருந்து பண்ணா யூடியூப்ல வருது
வீட்ல இருந்து பண்ணா யூடியூப்ல லைவ் ஸ்ட்ரீம் போதும் நம்ம செக் பண்றோம் சார் நீங்க இது ஷேர் ஸ்லைட் ஷேர் பண்ணுங்க
அவர் ப்ரோக்ரஸ்
சார் உங்க ஸ்கிரீன் இது வரலைங்களா சார்
வருது ஷேர் ஆயிட்டு
மேம் இக்னோர்
அவர் அந்த அவர் தான் இன்னும்
சொல்லுங்க
சார் நான் இங்க
இப்பதான் ஷேர் ஆகுது
சார் வந்து ஃபுல் ஸ்கிரீன் கொடுத்துருக்காங்க அதை பின்போஸ் பண்ண மாட்டேன்
சார் இல்லை சார் ஹோல் ஸ்கிரீன்
பின்போஸ்
வரலைங்களா சார்
பிபிடிக்குள்ள போஸ்ட் சார்
சார் உங்க பவர் பாயிண்ட் இது ஷேர் ஆகுதுங்க சார் சார் இப்போ நீங்க கொடுங்க சார் நீங்க முன்னாடி கொடுத்து கொடுங்க இப்போ அதுல பவர் பாயிண்ட் பிபிடி ஓப்பன் பண்ணுங்க சார் டச் பண்ணி ஓப்பன் பண்ணுங்க அவ்வளோதான் ஓப்பன் ஆகுது அதுல ஃபுல் ஸ்கிரீன் கொடுங்க சார்
பேச சொல்லுங்க யூடியூப்ல வருதான்னு பாருங்க யூடியூப்ல
வெளியே நான் அப்போ மீட் பண்ணிட்டுங்களா சார் மியூட்ல தான் இருக்கு எங்களுது
நம்மளோட மியூட்ல தான் இருக்கணும்
நீங்க பேசுங்க சார் எதுங்க சார் யூடியூப் ஆன்ல தான் இருக்கு சார் யூடியூப் ஆன்ல தான் இருக்கு
அது லைவ்ல தான் வந்து நம்ம கட் பண்ணி
யூடியூப்ல வருதான்னு பாக்கணும்
இல்ல நீங்க பேசினா அங்க
கார்த்திக் நீங்க பேசுங்க யூடியூப்ல இது வருதான்னு செக் பண்றேன் ஏன்னா இது உங்களோட தான் ஃபர்ஸ்ட் ட்ரையல் இல்ல நீங்க சீக்கிரமா ட்ரையல் பண்ணி முடியுங்க ஒரு நிமிஷம் ஜஸ்ட் சும்மா அதை காமிச்சு ஏதாவது பேசுங்க வருதான்னு வந்து பாத்துக்கிறோம் ஏன்னா யூடியூப்ல வந்து ஸ்ட்ரீமிங்ல வந்து வீட்ல இருந்து பண்ணா வருமானு தெரியல
பண்றேன்
வாய்ஸ் கேக்குதா?
நல்லா கேக்குதுங்க சார்.
கேக்குது.
நான் ஸ்கிரீன் விசிபிளா தெரியுங்களா?
சார் தெரியுதுங்க சார்.
Screen
தெரியுது.
சரி. இது ஃபார் எக்ஸாம்பிள் இப்போ
நான் ஜிபில தான் இருக்கேன், யூடியூப்ல பார்க்கல.
சரி
மேம் யூடியூப் பார்த்துட்டு இருக்கோம் சார்.
நான் இதை ட்ரை பண்றேன்.
ஃபோன்ல
யூடியூப்ல வருதுங்க சார். யூடியூப்ல வருதுங்க சார்.
ஸ்லைட் சேஞ்ச் ஆகுதுன்னு பாருங்க.
மாத்துங்க சார். சேஞ்ச் ஆகுதுங்க சார்.
சேஞ்ச் ஆகுதா?
சேஞ்ச் ஆகுது.
சரி. இப்போ ஒரே நிமிஷம். இப்போ வந்து நீங்க தெரியறது வந்து நான் வந்து வீட்டில் வந்து
ஓகே சார். சரி. இல்ல சார், நீங்க இது மட்டும் தான் வந்துச்சு. ஸ்லைடு இது மட்டும் தான் வந்துச்சு. ஓகே மேம். ஓகே ஸ்லைட் சார் அது பேசுறது
நான் செக் பண்றேன். பட் இங்க உள்ள மைக் பண்ணா நம்ம பேசுறது ஜஸ்ட் மியூட் பண்ணது கார்த்திக் சார் வந்து பேசுறது கூகுள் மீட்ல ஸ்மூத்தா கேட்கும். பட் யூடியூப்ல நம்ம இங்க பேசினா அது கேட்கும். அதனால நம்ம வந்து பேசாம இருந்தா யூடியூப்ல கரெக்டா இருக்கும். கார்த்திக் சார் பேசுறது கூகுள் மீட்ல கரெக்டா இருக்கும். யூடியூப் ரெக்கார்டிங் ஆஃப்.
சரி ஓகே சார். சரி இல்ல இங்க நாங்க பேசும்போது யூடியூப்ல வந்துருக்கீங்களாமா, அதான் நீங்க பேசுறப்ப நாங்க யாரும் பேசாம இருந்திருக்கோம் அப்படின்னு இல்ல நீங்க பேச நல்லா கேட்டு சார். நல்லா கிளியரா கேக்குது. அது கூட சேர்ந்து யூடியூப்ல நாங்க இங்க பேசணும் இல்லைங்களா, அது சேர்ந்து சிவராம் ஒரு நம்ம யாரோ ஜாயின் பண்றாங்களாமா. சார் ஒரே நிமிஷம் யூடியூப்
லைவ் மாத்திரம்